Hi, everybody. Happy Thursday. Welcome back. Thanks for joining us for session 2 of our harm reduction intensive training series. We'll go ahead and review our housekeeping and our agenda a little bit. Just to get us started, we want to invite folks to be present with us. If you're able to turn your camera on, please do so. It's really helpful for us to be able to see each other and kind of build knowledge and community together. If you're seeking continuing education credit, please stay for the duration of the training, participate in our discussion today, respond to any poll questions. I think we have a couple of those. And per the ASWB, it is required that your camera is on if you would like to receive credit. Questions and comments, welcome throughout. Again, you can do that by just unmuting, jumping into the conversation, or you can utilize the chat. You can send messages either publicly or privately to myself or Ryan. We'll make sure that you get your questions answered. There's going to be a course evaluation at the end of today, just like there was last week, a link to a Google form. Answer some questions, let us know how we did. We'll give you a course certificate in exchange for that, and that's also where you will receive that CE credit. Our closed captioning is enabled. If folks need that, please feel free to enable it by navigating down to your toolbar and clicking on Show Captions. I do notice we have a couple of people logged in under the same name. We want to make sure we're giving credit to everybody who's here. So if your name is not your name on the screen, I see like 2 Madisons, 2 Dre's, 2 Jajayas. I'm sorry if I just really mispronounce your name. You can either drop your name in the chat and we can change it for you, or if you go to your photo, your video on the screen, there's going to be 3 dots in the upper right-hand corner. Click on those, choose rename from the drop-down menu so we can get everybody their credit for being here. To prevent that from happening in the future, when you registered for this training, you got an email from Zoom, and the link in that email is how you should access the training. That's like your unique registration link, and then that way it'll log you in under your own credentials. Ryan, you want to talk about today's agenda?
Absolutely. So today, and remember, this is a 1-hour session as opposed to the 2-hour sessions that we had last week. So it's an abbreviated session. The remainder of the sessions will be these kind of 1-hour little chunks of info. So for today, we are going to do a quick review, and we'll keep it very brief, but if you missed any content or just as a kind of a refresher from what we talked about last time, a few of those slides that you'll recognize from last time in this review. We want to talk about harm reduction in kind of a definitional way still, right? Defining harm reduction and make this distinction between the movement of harm reduction and the practice of harm reduction, the day-to-day concrete practice of harm reduction. We'll talk about the principles of harm reduction. We'll talk about harm reduction with various high-risk behaviors. Understanding that harm reduction is not only being used in our practice with substance use. And then we'll wrap up with some Q&A. As always, we prefer you to get your questions asked along the way, right? Like, don't hold your questions until the end. In terms of learning objectives, once again, showing you the full list of learning objectives for the whole intensive series. However, today, our content is really going to focus on the 2 bolded learning objectives. So by the end of this 1-hour session, we hope you'll be able to continue to recognize safety and bodily autonomy as the primary goals of harm reduction. And then we hope you'll be able to list 3 harm reduction tools to engage with folks around various risk behaviors. So we'll talk through some tools as we go. Ryan,
I'm going to pause you for a second just because I noted somebody mentioned in the chat that one of the programs lost one of their residents today. So I just wanted to extend my condolences and say I'm very sorry to hear that. We certainly deal with that quite a lot at Pathways, and it never gets easier. So glad you were able to join us today, but I hope you're doing what you need to do to take care of yourselves. So.
Yeah, thanks for that pause. I didn't see that. Okay, let's do a quick poll. Want to get a sense of how you're feeling about the content that we covered last week and how you're feeling jumping into today. So let me launch that poll. Oh, Andrew, I wonder if you're able to launch the poll. It's giving me an error message since I think we're both logged in on the same.
It's up and running.
Okay, cool. So Let us know whether you're excited and eager to learn more today, whether you're feeling challenged but willing to dig deeper and keep going, or whether the content that we talked about last week left you feeling overwhelmed. There's a lot of new information, and maybe you're unsure if you're able to keep up. Hey, Brandon, I've had camera issues like the ones that we're seeing on your end right now. I wonder if you're able to turn your camera off and then turn it back on. Sometimes that fixes the glitchiness.
All right. I think everyone who's going to answer has answered. So I'm going to end this poll and share the results for y'all. Did this come up for, can folks see this?
Now it looks like my head's twitching.
Ryan, can you see the poll results too?
No, I'm not able to see it.
Gotcha. So about 70% of folks in the room said, hey, they're excited. They're eager to learn more today. I'm glad that last week's session left you wanting more. We've got plenty of it. So thanks for joining us again. And then 30% of folks in the room said, you know, I felt a little challenged, but I'm willing to dig in deeper, keep going. That's great. That's the right attitude to have. Thank you for showing up, even though sometimes this stuff is, you know, maybe new or slightly outside of our comfort zone. Yeah. And then nobody said that they were totally overwhelmed and unsure of their ability to keep up. So great. We're excited to talk more with you today. So I want to start with a brief review. Again, really brief, but just want to cover, you know, touch on some of those main ideas from last week and what we talked about. So we spent some time talking about the purpose and impact of stigma, right? Stigma really serving three main purposes. The first being to note that somebody is different from us, because when someone's different from us, we want to keep them out, right? That's the fallout, that's the impact of stigma, right? Is that we keep people out. We want to keep them out of our neighborhoods. You can't sit at our lunch table, you're not a part of our club, you know. And then also noting that folks are dangerous. When someone's different, they're dangerous, we want to keep them away from us. It's our natural human inclination to want to keep ourselves safe. So if we think that someone could pose a threat or a danger to us, we're probably not going to rent them an apartment. We're probably not going to give them a job, right? And then when we think people are different, when we think they're dangerous, we also want to discriminate against them. We don't want those people who are different from us and who are, you know, not holding the same kind of like values and beliefs and morals as us. We want to keep them down. We don't want them to have access to the same resources and benefits that like us upstanding members of society have, right? So that's kind of what happens with folks experiencing stigma.
We also looked at the fact that high-risk behavior or these things that are somewhat scary to us are very visible, they're in our face, but those things are often just the tip of a much deeper iceberg, right? Understanding that people engage in high-risk behavior as a coping mechanism, as a response to trauma. So then what's below the surface, right? Somebody's trying to survive something through some of these behaviors that we would categorize as high risk. They're using these tools to survive. And it's up to us to ask that next question. What are they trying to survive? And that's where the work really can be, rather than only trying to eliminate or high risk behavior for its own sake.
Now, we also spent some time talking about how harm reduction is not just something that we're doing to our participants, right? It's something that's a part of our daily lives as being humans, right? Putting on our safety belt, driving by the speed limit is harm reduction. The act of just getting in a car and driving to work is sometimes quite dangerous, right? We know that going to the beach, getting a little vitamin D, getting a little sun, that's good for us, but too much of it is also dangerous, right? We put on our sunblock, we wear some protective shirt, we sit under an umbrella, right? So harm reduction is just something that we're doing all of the time, and want to think about it as expanding beyond. It's this service that we only do for people who have X, Y, and Z problems, right? Harm reduction is just part of being a human being.
I think we did a pretty good job last time also of really hammering home this idea that if we were to kind of list two main goals of our harm reduction practices, these two things on the screen, safety and bodily autonomy. We know that we're operating in a really abstinence-focused system. And so we're looking for ways to bring this harm reduction approach, these ideas around safety and bodily autonomy into our current work. Because we understand that these things are antidotes to the stigma and shame that people face.
Ryan and I are fighting over who's going to do this slide. So before we kind of like jump into the meat and potatoes of today's conversation, we just want to check in and see, since last week, what have you been thinking about? Did you try to put anything into practice and then start scratching? Maybe I don't really understand this, or maybe I have some more questions. Just offering these three kind of discussion points if anything comes to mind. What are you squared away with? What are you like, yeah, I get that. That's great. I'm going to use that. What ideas are you still wrapping your head around? What feels new to you, or you're not totally sure about how to put that into practice where you work in your setting? Or maybe like, what's something you saw from a different angle? I never thought about it like that before. This makes more sense because I heard it said with these specific words. I don't know. What are y'all thinking about? What's come up since last week?
I guess I can try to start, although I'm not sure if it quite falls in the parameters, but I just got off the phone with getting someone connected to SSI after years of going through the process, and he's going to be getting a significant retro check. Now he's been trying to stay sober. He's got some real liver issues and could go into a coma if he starts drinking again. Of course, I'm worried about that, but that's not my decision to make, you know. So I've been thinking about it, but what am I going to do, you know?
That's a great example, Brandon. Thanks for bringing that up, because that's something that we deal with in our work all of the time, right? Participants who are trying to change or manage their relationship to substances and then get a huge back payment, right? And for a lot of folks, it can be like, hell yeah, it's party time, right? Like I got thousands of dollars, especially for folks who have lived for so long without so much, right? So there can be harm reduction conversations around budgeting, right? Like what things do you actually need versus what do you want versus how do we make this last, right? And then of course there's those like weird parameters around like how long you can have so much money in your account to still qualify for benefits. But yeah, certainly budgeting, talking about large sums of money, talking about how to stretch a check to be able to meet your needs is a huge thing that we do in harm reduction all the time. And one of the tools that we'll talk about in a subsequent week that we'll also send you a copy of is the honest budget. So that's great. Thanks for bringing that into the conversation. Maybe let's hear from one or two other people. What have you thought about? What's come up in relation to harm reduction in the last week or anything we talked about in our last session?
I have two patients who there's a pretty wide delta between their expressed goals and what they're doing. And I try to create as much space as I can in the conversation to say, like, these are choices that you have. Like, you shouldn't do something for me. I will work with you kind of regardless of where you are. And yeah, these are people I've worked with for a long time, and they're just really struggling to have a conversation that corresponds to or to effectively predict what they're going to do.
Yeah, I want to acknowledge that harm reduction like isn't easy work, right? And seeing folks make decisions that are maybe different than the decisions that we would make ourselves, right? Like that's not what I would do in that situation. And sometimes watching folks make decisions that could actively cause them harm. That's hard. That's a hard thing to kind of like witness in the workplace day after day. So, but continuing to show up and say like, regardless of what choices you make, I'm still going to be here. I'm still going to walk alongside you. I think can be really transformative in our relationships with the people that we're working with. So thanks for that. I saw Cynthia and Mike, and then we'll move on. Cynthia, what are you thinking about this week?
I'm trying to unmute myself.
Oh, you were unmuted and then you went on mute again. There you go.
Okay. So I have a program for 22 men homeless, formerly homeless once they're in my program. But I've been working with somebody to get him in, and he's an outside sleeper. So it's been rough just getting his paperwork together. And he came in all proud of himself because he had a social security card, but he was in a wheelchair. And I said, hey, what happened to your bike? Why are you in a wheelchair? And he said, oh, my feet are always hurting and blah, blah, blah. And I said, oh, so I was going to take him to the Y and show him the room because there's a lot of mental health things going on. And he said, can I use the bathroom? I said, of course you can. So he was in the bathroom for quite a while, and I knocked on the door and I said, are you okay? And he said, can you look at something? I said, yeah, quite well. I said, are you decent? And of course I will. But when I opened the door, he said, Cynthia, look at my foot. And his foot was so swollen and black and had hardly any skin on it. I said, I just have to call an ambulance. And he said, oh, you think so? And I said, yeah, will you go if I call one? Because, you have to have their permission. And he said, yeah, I will. So he was admitted, and the next day, his brother called and said, well, he might have one of his toes taken off. I said, oh, that's terrible, blah, blah, blah. The next day, they were going to take off his foot. And the next day, they ended up taking off his leg. So now he's in a wheelchair, for quite a while. But I guess what I keep thinking of is, so I told him if he didn't go to a rehab, he couldn't come to my program, because that means you're not going to take care of yourself. And this is serious. And I don't know what his drug of choice is, but I'm going to say he uses a needle. And if he's in the hospital for 3 weeks and then at a rehab for, say, another 6 weeks, you don't have to be sober to be in my program. And I don't know how to say, let's keep this going, because everybody in the program uses, in the building, just about, not everybody, but I don't want him to come there and die. And sorry, I'm crying. Can you tell?
It's okay. It's okay. I would feel very emotional about that too.
Well, I already lost 4 people to overdose.
Yeah. And
I was able to secure funding for the entire building to get Narcan boxes and, the rescue kits and everything. So I don't know. I'm sorry. I don't know how to start a conversation with them.
Yeah.
I don't want to go in and say, you're not going to use when you come out, but who am I to say that,
Yeah, and I think sometimes we need to remember that there are lots of environments our participants are going to be in that we don't have any control over, right? So like if this individual comes back to your program and is surrounded by people using, but he doesn't want to use, right?
But we don't know. I don't know. He didn't want to go to rehab, so I thought he wanted to come back to, start all over again.
Yeah. Well, if he comes back, right, and on his own volition, he's like, I don't want to use, right? He might say to you, maybe this is not the program for me, and maybe I need to find a sober living facility, right? But also there's going to be plenty of other environments in the world outside of that program where he's exposed to substance use, and folks have that choice, right? We can't chaperone folks 24/7, right? And so we can express our concerns, we can offer resources, we can offer information, but ultimately, right, folks are going to make those choices about, you know, their bodily autonomy, what feels right for them. And certainly, I think we spent some time last week talking about, like, how can I express concern for someone, you know, maybe share about some of the realities of what I've seen in my work, while also making sure to not be like overimposing, like, these are my values and my wishes and my fears, like letting folks, you know, ultimately steer the ship, even if it really is painful to watch the direction in which that ship is headed. You know, it's a really hard thing to balance. So thank you for sharing that with us, Cynthia.
Thank you.
Of course. Mike, you want to jump in for a second before we move on?
Sure. Very quickly, I just wanted to say I really appreciated your opening questions, and then the whole conversation around the power of choice and autonomy. And I just think those are lasting thoughts that I've had since the last session. So thanks.
Oh, thank you so much for contributing that. Appreciate it. Glad it was helpful. Okay, so let's spend a minute talking about the differences in, like, kind of the way we talk about harm reduction. So just like we would do in like a housing first training, we'd say, like, here's the difference between taking like a low barrier approach to housing someone or a housing first approach. And here's what actually a high fidelity housing first model looks like. They're two different things. So similarly, we sometimes try to parse out the difference between like capital H, capital R harm reduction and little h, little r harm reduction. So capital H, capital R harm reduction is this movement for social justice built on a belief in and respect for the rights of people who use drugs, right? That's as defined by the National Harm Reduction Coalition. We look at harm reduction a little bit more broadly and talk about it as like anybody who's engaging in any kind of high risk behavior, right? We want to respect and believe in their rights. They get a right to choose what to do, what not to do, right? And then the little h, little r harm reduction is this set of practical strategies and ideas that are aimed at reducing the negative consequences associated with drug use or other high risk behaviors, right? So most, like, if you ask like a normal pedestrian on the street, what's harm reduction? They're going to be like, oh, that's when they give you clean needles, right? And that's just like a piece of what harm reduction is. Like, syringe services programs are hugely important. We got like 200 of them operating in the United States, but that's only a small piece of what harm reduction actually is, right? So these beliefs and practices are the ideas that, like, we're going to support people to use their self-identified survival tools. We're going to meet people where they are. We're going to prioritize health and wellness for everyone that we're working with at all times. And I think maybe one of the most important things is that we're going to both acknowledge and then refuse to perpetuate that stigma and those cultural norms that have historically left people isolated, alone, and ashamed, right? Folks are not getting help, and they're not going to get better if they're isolated, alone, or ashamed.
I think it can be difficult as we explore harm reduction strategies, right? The little h, little r, to know, like, am I in the ballpark? Am I doing the right thing? How do I know that the intervention I'm deciding is a harm reduction aligned one, or I'm faced with an issue, this person who's now has his leg amputated? How do I know what's my next step? How do I start that conversation, right? And I think it can be true that you, Cynthia, may approach that conversation in a harm reduction aligned way, and it could sound very different from the conversation that I have with that person that is also a harm reduction aligned conversation. And so how do we know what we're doing? How do we hang our hat? And so I want to present these principles as a way to anchor potential interventions, anchor these conversations. And you say, like, my opening question to this person may be such, and then maybe one way to start to evaluate that approach may be, all right, well, let me look at these principles and see how does it align with that question that I want to ask, that direction I want to take the conversation. So let me jump into it. These are pretty broad principles, not the same ones that you'd see on like the National Harm Reduction Coalition's website that is very drug user centered. This is more like healthcare setting, housing, homelessness. It's broader, right? So health and dignity is one way that harm reduction is focused. caring for people's health as individuals, caring for the public's health in a public health sense. And it's also about caring for and respecting people who are going to make choices that have valid reasons behind them, right? People have this set of choices, and whatever choices that they are going to make are valid. Often those choices are based on kind of responses to trauma. And so we're trying to transparently understand benefits and harms with people and allowing the dignity for them to sort of do that in an open and honest way. Harm reduction is also participant-centered, kind of keeping the therapeutic relationship at the center of care, sometimes at the exclusion of many other things, right? I could do this thing, but it's going to harm therapeutic rapport. You may be actually fighting over some, influencing autonomy in that case, right? And so kind of always being participant-centered. I know that's cliche. I know no other therapeutic approach would say, don't be participant-centered, but I think harm reduction really holds this as a core centerpiece, right? Participant involvement. And so using strategies like shared decision-making. What do you think are your next steps? Here are some pros and cons. Let's explore all the options, really using extremely informed consent, not in like a form, you fill out this informed consent so I can talk to your insurance provider, but like, here are some potential things we can explore. Here's some education I can offer. Here are some end results and consequences that can come up from that. Informed consent around people's actual decisions. Yeah, he could keep using. What's a potential consequence there, right? And so involving people in those conversations more deeply, bringing them into case consultation, right? How nice, instead of us doing treatment at somebody, to pull them into the conversation. And then ultimately, the kind of next step of that is participant self-rule. Yeah, we get to kind of contribute. We get to offer suggestions, education options, but ultimately people are going to make the decisions they're going to make on their own anyway, right? And so ceding that power as a way to reduce the hierarchy that is inherent in service provision and allow people to claim that autonomy and move forward on their own with our support. Harm reduction also recognizes inequalities and injustices, right? There are realities of marginalization, oppression, and stigma that people face. We've covered that in depth already so far. And harm reduction recognizes that those realities influence people's vulnerability to harm, right? Andrew gave the example of the person of size eating fast food on a bench and all the judgment that can come that way. But if it's a fit person, less judgment, right? And so there are realities that affect people's vulnerability to harm and also their capacity to deal with harm. Our identities are risk and protective factors in dealing with risky decisions and with harm. Harm reduction is also practical and realistic. I'll speak for myself. I'm never going to achieve 100% healthy behaviors. I'm going to continue to take risks that will be damaging to my health. But that's okay. Well, we can recognize in harm reduction and the small victories along the way that are people claiming their autonomy and moving in the direction of greater wellness. And so we can celebrate small victories, something that may work for one person and may be practical for them. Yes, I can do that. I can cut back to 8 bags a day, instead of 10. I think I could do that. Another person, that's a step too far. And so what about if we just make sure that you're always using with somebody, right? There are levels to this, and it has to be practical and realistic for the individual. What are you willing to buy into and do? And then lastly, I think this one is really core in a housing context, accountability without termination. This idea that we're not firing people from care simply for not meeting the goals that we're upholding for them. Stressful events is what Andrew called them last week, right? And so, yes, we can have conversations around accountability. You think that person that lost his leg doesn't recognize that is a significant consequence, right? Obviously they do. But firing people for kind of showing the reasons why they're in our care in the first place doesn't allow us to interrupt that cycle of shame and stigma, right? So these are the principles I wanted to present to you, and we'll talk more about the way that these show up in the work and in the tools we use as we go. So I want to kind of, again, jump into some tools a little bit. I hope it doesn't sound too cliche. Language does in fact matter. It matters for us as providers when we're talking to our colleagues together, when we're creating program policies. It matters when we're talking to our participants. And so as service providers, we call we call them participants. We call substance use certain things. We have names for things, right? Labels that we put on things. And so the question we have to ask ourselves is, this word that I'm using in the context of participant care, is there an implicit judgment in that label, right? And how we talk to our colleagues about our participants, and what about how do people perceive themselves, right? When we're using these terms, what terms do they use for themselves and about the behavior that they engage in? And so if there is a judgment built into some of those labels, what is that then communicating to people, right? How is it influencing them? How is it influencing their decision-making process? How is it influencing their sense of self? And then lastly, if these labels and terms and language that we use has implicit judgment, it communicates negativity to people, how does that impact the therapeutic relationship that we have with them, right? If we're centering that therapeutic relationship, but our language is doing other stuff, we're already off track, right? And I think language is so easy to get caught up on, just like, oh, we've always said it this way. We've always done it this way. I grew up calling it this. Or like all my colleagues call it this. It must not be bad. And I think we have to really interrogate some of those terms and the language that we use through the lens of, how might this be hitting somebody? How might this be reinforcing that cycle of stigma and shame? Kind of another way of exploring language here is through this idea of relapse versus recurrence of use. And relapse is a very common term. Many people wouldn't nitpick with the idea of relapse. Even like I think about motivational interviewing and the stages of change, you're up through like maintenance and then eventual relapse, with a recognition that like change is not linear and that sometimes people fall back. But I guess I wonder whether that implies a sense of failure. Just that word relapse, right? I was trying to do this thing. I failed. I relapsed. Doesn't mean I won't still try again, but that has an effect on people. That is a draining effect that it can have. And so often in a harm reduction context, we'll use terms like recurrence of use. And so just a way to kind of illustrate this use of language and how it affects people. If language and attitude communicates judgment, which it does, positive and negative judgment, that judgment then contributes to shame. And when people feel that shame, they're likelier to hide from us, right? From the people that are using that language. And so when somebody is hiding behavior, yeah, they'll tell you some things. I might tell you a little bit about what I'm doing, but if I feel some sense of shame around you, I'm probably going to hide some of that, right? Pieces of my identity or what my behavior is. And when I'm hiding, that's much more dangerous. I'm not in community. We're not having an open dialogue about harm reduction strategies, right? Because you're busy hiding. And so it's a much more risky proposition for people to engage in whatever they're engaging in isolation, right? Rather, our language should be inviting to people, that non-penalizing honesty, right? You can say what you want to say. You already did it. Let's talk about it in a non-judgmental way. It's this open and ongoing dialogue. Really going hard on the language here. And I know this will not be a new set of concepts for anybody in the room, but using person-centered language, right? And it's exactly what it sounds like. It is language that centers the person rather than the disability or the problem, right? And so some examples of more stigmatizing language that we still hear. We always want to say it's 2023, like nobody uses language like this, and frankly, that is malarkey. I'm going to use that word. Some stigmatizing language, calling people junkies, calling people addicts, or even drug abusers, or even like we do trainings all the time where people say, and I'm not judging, it just comes up quite a bit. They're a substance abuser, or substance abuse is their main challenge. Drug abusers is an example there. Schizophrenic. Oh, my schizophrenic sister, right? People that care about other people that still kind of buy into and use stigmatizing language. That person was an inmate, is an inmate, or they're an ex-offender. Oh, what a great thing that this person is doing to turn around their life. They were an ex-con or they're an ex-con. right? And then again, the use of the word relapse. On the flip side of that, we can turn these terms around and make a shift to more person-first language. It is a small action, but it sometimes has a really big impact, right? So more person-centered ways of having these conversations. A person with a substance use disorder, right? Not a person who's a substance abuser, but a person who uses substances, substance user. People living with drug dependence, a person living with drug dependence, a person who uses drugs, a person who's living with schizophrenia, a person experiencing schizophrenia, people who are incarcerated, a returning citizen, welcome home, you're a returning citizen. And then once again, recurrence of use. Again, I know that this is probably not, brand new information to you, but it's just an ongoing reminder that we're dealing with unique individuals who are more than a sum of their symptoms and risks and problems. And folks who aren't using person-centered language, they're not necessarily trying to perpetuate stigma. That's not their goal. And it can be hard to make that shift, especially when you're like, I have a good heart. I'm not trying to be stigmatizing. But when we can speak from a more strength-based perspective, it helps us to really convey that respect, that dignity that we talked about in the principles, and a belief in resilience in our clients, right?
So I'll say when we have conversations with folks about challenges in housing related to substance use, I'll usually hear folks say things like, well, he's going to get evicted because he's using. And I want to spend a moment thinking about what's the separation between drugs and behavior, right? Typically, a lot of times, the reason that somebody might get evicted from a unit, it's not the actual substance use. People use drugs in their homes all the time and nobody else knows about it, right? It's the behaviors that often come along with certain substance use issues that trigger those challenges, right? So if you're using in your apartment, you bring all your friends over and you're making a lot of noise, well, you might get evicted because your neighbors are complaining about all the people over and all of the noise, right? Or if you're smoking so much weed in your apartment that all of the other apartments in your hallway are full of weed smoke, right? Then, okay, that's related to the substances, but it's like the behavior versus the actual drug, right? Like what's the actual problem? So talking about harm reduction as it relates to helping keep people housed specifically, I want to say first and foremost, housing itself is harm reduction, right? Giving somebody a roof over their head, a safe, stable place to live, we are automatically keeping people safer and healthier than they would be sleeping outside on a park bench, right? Sheltered from the elements, they're going to stay warm, they're going to stay dry. Harm reduction itself, housing itself is a form of harm reduction. When we see challenges to maintaining that housing stability, we can use harm reduction by focusing on specific behaviors or patterns that are challenging somebody's continued tenancy, right? So think of the example of, the landlord's receiving numerous complaints about this participant who's bringing over all their friends, partying until the wee hours of the morning, right? That's a pattern that could lead to eviction for someone. It might be related to their substance use, but what we talk about is okay, can you move your party to a different location? Maybe you can go to your friend's house instead, right? Or maybe we can set up systems to reduce risk, right? We make a plan that you're going to turn the music down at 10 p.m. instead of letting it blast until 2 a.m., right? If we know that somebody is having all of their friends over, and it usually seems to happen, there's a lot of noise or a lot of issues around the 1st or the 2nd of the month, that might be related to somebody's income, right? Their check hits the bank and it's party time, right? So maybe we can talk with that person about breaking up their check a little bit, right? Instead of getting, a huge lump sum of money on the 1st or 2nd, you get $50 once a week, $100 once a week, right? So some of these strategies we can use to reduce some of the risk associated with the behaviors that are maybe associated with the substance use. So rather than just saying, you have to stop using drugs or you're going to get evicted, let's look at the behaviors associated with the drug use that are maybe causing problems with your landlord or your neighbors, right? The supportive monitoring for safety maintenance is just like your home visits, right? We actually need to go see people in their homes to check in on them. We don't want to call it a home inspection, but just like, I'm coming to visit you in your home. I'm a guest in your home. Talk to me about how it's going, right? We want to see that the unit is in good condition. We want to see that the participant is in good condition and that they are managing well as a tenant. And the best place to do that is by actually in the home with them. Someone will come into your office and sit down at your desk and tell you all kinds of things, right? But when you're actually in their home with them, you're going to learn a lot more about how they're interacting with their neighbors and how well they're managing as a tenant. I do want to say, we're working with folks with incredibly high levels of need, right? Folks who have been experiencing chronic homelessness, who have maybe never lived independently. Therefore, they have never learned a lot of the skills that we all take for granted, right? Like, we got to take the trash out if we don't want the kitchen to smell. We got to do the dishes if we don't want to get roaches, right? Some of our participants have never had the opportunity to learn those skills, right? And so we cannot expect overnight miracles. We can't expect that just because we've given somebody a roof over their head, that all of those other kind of challenging behaviors are going to resolve on their own. A lot of our work is around helping people learn some of those like basic ADL skills, right? And if folks are interested in changing their relationship to substances, right? We've been living with our survival skills and our coping strategies for a really long time. Even if we want to change, it often doesn't happen overnight. Think about any behavior in your life that you've tried several times to change, right? It probably wasn't just like, oh, you had an idea and then the next day you put it into action and never looked back, right? Like, we start, we stop, we make progress, we take a couple steps back. So we can't really expect overnight miracles of our participants either. We like to use the phrase like, meet people where they're at, but add on, but don't leave them there either, right? Like, we don't want to just get somebody into housing and say, we're meeting you where you're at. And where you're at is that you chaotically use substances and get evicted from every place you live, right? Like, we can also help folks to understand, like, where do we go from here? Like, what's the next step for you? How do we achieve like more health and wellness, more stability for you, more safety, more bodily autonomy, right? So our job is to help our participants identify what behaviors are perhaps no longer serving them, right? What behaviors are not aligning with their goals and beliefs. A lot of our work is just pointing out discrepancy. I hear you say you really love this apartment, right? But I've noticed that X, Y, and Z behaviors are really ticking your landlord off. And he's been talking about maybe evicting you, right? What do you think about that? How do you think we can keep you here in this apartment that you like, right? Pointing out that discrepancy between goals and behaviors, and then letting participants come to their own conclusions about how to address those things, right? We can steer them in the right direction, give them some ideas, but they have to be the ones that are saying, this is how I want to handle that, right? So we can ask, well, great, how can I help with that? I do want to say that this work, again, is highly, highly, highly individualized. Harm reduction work, housing first work. There's no book somewhere that's like, when you encounter this problem, here's your course of action. There's no like 3 strikes and you're out. There's no, well, I have this one participant named Larry, and on the 3rd Thursday of every month at 2:27 in the afternoon, Larry does this one thing, and that means we can evict him, right? Like, there's none of that. There's very few like if this, then that types of situations. So our responses have to be individually tailored to the folks with whom we're working, right? We recognize our participants are at like different stages of recovery, of change, from their substance use, in their mental health recovery, in their recovery from the experience of being homeless, right? So our interventions, in order for them to be effective, have to be tailored to each individual, and then each individual stage of change for each of their individual challenges and problems, right? So this is where all of that like creativity, patience, empathy, all of that has to come to the table if we're going to be good at it. Harm reduction shows up in our mental health work too. Some of the kind of most common places or ways that we see it at Pathways is sometimes around self-harm, right? So can we talk to folks about punching a pillow instead of punching yourself, or punching a hole in the wall, right? Certainly there's going to be some challenges with tenancy if we're putting a lot of holes in the wall or ripping the doors off their door frames, right? Can we talk to somebody about punching a pillow instead of breaking their window? Can they break a dish instead of breaking their window, right? Like these little changes that we can make that maybe have fewer consequences. We do see a lot of folks with serious persistent mental illness sometimes lacking a full understanding of their health conditions, which can manifest as like reluctance to seek treatment, mistrust of providers. A lot of times it can look like self-neglect, right? But sometimes these issues are really just like rooted in fear for folks because of previous experiences, because of not having a full understanding of some of their challenges, right? Folks choosing or to take medications or not taking medications is a big area where we can struggle, right? Just because we think somebody needs to take medication doesn't mean that they think they need to take medication. Or maybe they've tried medications and those medications have had terrible side effects that they didn't want to deal with, right? Ultimately, our participants have agency over determining whether or not they want to take meds. They're entitled to make that decision, just like we're entitled to make that decision. I think a lot of this becomes even more complicated for folks who are holding other marginalized identities, right? Think about somebody who experiences psychosis but isn't a native English speaker. Maybe, think about undocumented folks or transgender folks. Sometimes seeking medical care, mental health care becomes a lot more complicated when the doctor's office can be a site of traumatic and dehumanizing experience for folks. So we do see a lot of aversion to folks addressing their physical health care issues. And when we think about like, what does it mean to work with this from a harm reduction point of view? It's those same principles that we've talked about. We have to remind ourselves that our clients are the experts on their own lives and their own experiences. It's up to them to decide what they want to do with their body, what feels good, what's right for them based on their circumstances and preferences. So harm reduction in mental health can kind of help us conceptualize the safest way to do this. That being said, the situation doesn't always turn out great, right? Like sometimes we offer like a lot of ideas, a lot of resources, and folks, just like with substance use, continue to make decisions that are harmful to them, right? We can't prevent that. We can't prevent the natural consequences of people's actions, right? But what we can do when an intervention doesn't go as planned is we go back to the drawing board, right? It's a normalized part of the treatment process. We have to try out what works. It's going to be different for different people. But our participants will learn from being allowed to practice decision-making, right? So they learn from that experience and then perhaps make different decisions in the future.
Moving into the domain of health, exploring harm reduction conversations in a health context. We know this first bullet point here, right? There are a ton of barriers to accessing medical care for the folks that we serve, whether it's their anxiety or their fear of what may be coming, or the uncertainty of what's going on. Perhaps they know that they need a hospitalization to deal with a critical medical issue, and they're really concerned about what's going to happen with withdrawal. Am I going to get the medication I need to sort of like survive this hospitalization period? The stigma that we know can come through from medical providers. What about the interaction of their various medications along with what they use in terms of substances? So there's a lot that keeps people away from accessing the medical system. Our experience here at Pathways is that the principle of practical and realistic is so crucial here in this kind of medical health domain, right? And having practitioners that are willing to say, this is the medication you need, or like, this is the intervention you need. That doesn't work with how you're living your life right now. I know that you're not going to be able to take that medication or stay in the hospital for this length of time. Here's another intervention, not as good, right? Like not my preferred intervention for you, but it's practical and realistic for you, one that you're actually willing to engage with. Yeah, you might take this medication because of different side effects, or you may undergo this treatment. It's more palatable to you. And so having providers that are willing to say, it's not the best option, but it's an option, and have people buy into that, without removing that stigma and shame, I think is so crucial. We see that with both kind of physical health providers and mental health providers, right? Our psychiatrists willing to say, or experiment even off-label uses of, our psychiatrist was just telling me the other day, folks that are dealing with meth addiction and treating that with benzos. Oh, that's actually not working. He's starting to explore using ADHD medication to treat a meth addiction, right? And really just getting creative and practical and realistic. Here at Pathways and using a housing first model, we definitely use integrated care, have an integrated care clinic on site, which is so crucial, right? It promotes and normalizes all of this kind of continuous communication between service coordinators, the case managers, the psychiatrists, the primary care physician, right? Having all those people in close contact, in close proximity and communication to really deal with what people are experiencing in a holistic way is super crucial. We also use a tiered assessment model. It's pretty simple, kind of a step 1, 2, and 3 in terms of who needs extra support. Who do we need to send nurses out to the home to? What about even the primary care physician going out to the home for certain people? Versus some folks that we know we can check in by phone or maybe just need the once a week visit. COVID has really kind of created the need for prioritizing resources. Staffing shortages have created that need. And so we've made heavy use of telehealth also, right? And even making use of a program where we were actually giving people sort of a tablet called a GrandPad, has no street value, can only kind of connect to the network so that they can communicate with providers. And being able to check in with people in their homes through telehealth means, right? Doing a ton of medical care in that way, much more accessible to some of our participants. So just want to kind of note some of those critical challenges and having healthcare providers that are willing to be part of the conversation constantly, but also willing to experiment, to get risky on their own about what's possible, and really buy into these harm reduction principles. Okay, want to offer another tool in these conversations. I'm thinking about Nathaniel's conversation around like, yeah, I'm doing that. Like, I see your goals are this and I see your behavior is this. There's a discrepancy, but over time, not seeing any movement or not seeing anything kind of shake loose. Another part of those conversations that we often have is the readiness ruler. You may be familiar with this from motivational interviewing. It's a tool where we can start to gauge in a somewhat concrete way how important a given change is to somebody, how ready for that change they are, and how confident they are in making that change. And so we're asking somebody in various domains of their life, we want to get specific about this, not all or nothing conversations like, how important is it for you to stop using drugs? How important is it to you to reduce your use by this amount? How important is it to you to maintain this housing, this particular unit? I love this unit. I'm so happy to be in this unit. I never want to lose this unit. I will do anything that I can to keep this unit. I'm at a 10 on the importance scale, right? Interesting. Okay. But you're still having a lot of parties, right? How come it's a 10 and not a 5? Well, this unit has enabled me to have a relationship with somebody, to cook dinner for them, to feel cozy, whatever the reasons are. You can start to elicit people's own interest and motivation for potential change, right? In a concrete way, right? Through a 1 to 10 rating scale. And we can have that conversation related to mental health.
I need a cigarette. Can I have one?
And related to kind of any other risk-oriented behavior or domain in their life, right? So the first question is, how important is it for you to talk about harm reduction in these areas? The next question is, how ready are you to talk about it? Somebody may say, this is so important to me to maintain this unit, but I'm not quite ready to talk about a change. I'm really only a 2 on the readiness scale, right? Interesting. What would it take to bump that 2 up to a 4 or even just a 3? Well, if the doctor said this was going to be a consequence in the next month, it might make me a 4, might even make me a 7. Interesting. So now we're starting to understand that there is a readiness there, but the consequences aren't severe enough, or maybe the setup is not quite right. If I could just get back in touch with my ex, they were such a good support for me. Or if I could just get connected with X, Y, and Z support group, then I'd feel more ready, right? Now we're eliciting their own motivations and reasons for change. So in all of these areas, we can have that conversation. And then the last one is, how confident are you in your ability to talk about harm reduction in these various areas, right? I think it's really important. I'm totally ready to make a given change, right? Some little tweak to my life, but the people that are around me, if I start making a change, I'm gonna lose all my support, my income, I'm gonna lose X, Y, and Z, or, you know, there may be some barrier that will present itself when you start talking about confidence in making a change with people, right? So there's something that's a blocker. And when we can elicit those things, oh, we have a whole other direction to go with our case management supports and services and our conversations, right? What do we do about removing some of those barriers, right? We can engage the whole team, the whole integrated care team around removing some of those barriers, right? So the readiness ruler is a part of motivational interviewing and can be a crucial tool to explore over time whether anything is changing for people, whether they even want to change, and explore that ambivalence, that feeling of both ways about a given change, and start to plan for the future. All right, we've reached the end of our content. Want to open it up for any kind of questions, thoughts you're having here at the end of session 2. I know I just like dropped the mic very abruptly. Gather yourself.
Is anybody familiar with the readiness ruler? I know it's like very commonly used in trainings around like motivational interviewing. I'm just curious if folks have ever applied that to conversations around harm reduction.
I mean, I've applied it to the exact conversation I've been talking about, or specifically one of them where this patient left a hospital against medical advice and has one of the bones in his leg is broken, and the pathway forward is actually unclear. There's some chance that the bone set in a cast is approximating, and there's some chance that it needs surgical intervention. And there is an order for an X-ray that's been there for weeks. And the longer we wait, the more likely it is that they will need a more complicated intervention. And he has to go about 4 blocks from where he's staying to make it to the emergency room. And I've called transportation and also said to him, like, he's saying, this is really important. This might be a pathway to me having a bed that's more comfortable than being in a shelter, because I might get back inpatient in the hospital. Also, I know that my leg might be getting worse. He's accepted transportation. And so the conversation has been recently like, what's getting in the way between the doorway, between getting out of a ride and going in the front door? And I'm not blaming you. I'm asking, is there anything that we can do differently to support you? Also, if this is the thing you want, you don't have to want this, but if that's the thing you want and you're telling me that, you know, you're saying it's important, how can we change what the game plan is? And what I'm getting is, wheeling myself over there feels impossible. I'm going to have to wheel myself through people who are going to offer me substances. I know I'm not going to make it there. If you call a ride, I will make it there. And it doesn't happen again. And I have a limited transportation budget and want to keep stepping up and offering him like as often as I can. But I'm also aware that that's possibly preventing me from calling rides for other patients.
I think that's where some of our, thanks for sharing that, Nathaniel, where some of our challenges around harm reduction meeting ethical decision making, making sure that folks are getting treated fairly, that providing services for one person doesn't kind of like supersede or outweigh the needs or the rights of other people receiving services. Yeah, that's super challenging. And, you know, these tools, like I said, are not, they're going to elicit more information. More information is always helpful, but more information doesn't always lead us to concrete and easy answers for how to deal with these challenges.
Also, Nathaniel, I just want to affirm, like, what an incredible like set of conversations you've been able to have with that person, and in no way would I have suggested anything different, right? And so it sounds like you have a really good rapport with that person, know that person well, and also have a pretty good grasp on all of these concepts, of course. Yeah, and it can be so difficult to sort of know that, like, I know I'm asking you the right questions, I know we're having the right conversation, and still we're not seeing a result that we would love to see for somebody. That's really hard.
Thank you. That's reassuring, because there is always the like, maybe if I'm more creative, we would be able to solve this. And I
saw that Ryan dropped the link to the evaluation for today's session in the chat. You can click on that now, or I'm going to send a follow-up email in a few minutes that will have that link in there too. Wanted to offer space for any other questions or comments before we conclude for today. Thanks for folks being here and hanging out with us, and we'll see you next week, same time, same channel. Hope you have a nice weekend. Take care, everyone.
Have a good weekend.
You as well.